Hello, my name is Mort Kern. I'm interventional cardiologist in Long Beach, California, and I'm here with Dr. Javier Escaned, interventional cardiologist from the Hospital San Carlos Clínico in Madrid, Spain, an expert in coronary physiology and particularly interested in microvascular disease. And we're going to talk about safety of deferral. Why is deferral of interventions worthwhile? How do we use physiology to make good decisions for revascularization or not? And should we be concerned about the safety of deferral using our current physiology?
Yeah, thank you, Morgan. Well, as you say, probably the reason because deferral of revascularization with physiology is important is because I will say that most of the benefit in everyday practice from using guide wires and pressure guide wires comes from avoided and needed interventions. And discussing about it and reassuring the colleagues that it is safe is also important because many colleagues may feel uneasy about the fact that they see an stenosis that angiographically looks severe or whatever, and they have a FFR value, an IFR value that is telling that the stenosis is not severe. And they have to face the responsibility of actually not treating the stenosis. Yes. And that's the reason because I believe it's really important that we address this topic.
So I think one of the strongest issues that people still struggle with is the angiographic physiology disconnection. That is a 60% lesion in a symptomatic patient of some kind, and the FFR says it's okay, but the eyeball says it's not. What should we tell that person?
Well, I think we should tell them that, we keep, in a way, following the same groups left by angiography in the 60s. We still, have been trained, probably, that, if you see an stenosis that looks severe, the patient will be always better off if you treat it. But actually, it's in a way, there's a disconnect also. There is a problem of understanding reality and data. Data is telling us that angiography is a very poor tool in telling you if stenosis is functionally severe or not, because there are many other factors than, the severity of the narrowing influencing this, the microcirculation, whether there is viable myocardium, whatever. The second one is that we have to be very humble about the benefit of revascularization. We are waiting for the published results of ischemia.
Yes.
The trial, but in a way, what we know so far of the trial is telling us something that we already knew, that we only help patients when we do revascularization when we treat an ischemia-generating stenosis.
Right.
There is no other cosmetic or, say, other reason for treating stenosis unless for that. Right. I think that's the reason because, we have to understand that it's true that we have to change the paradigm, understand that we rely much more on objective evidence of ischemia, and that also understand that it's safe for the patient in the long term.
So yesterday you told us some very important facts. One of them was that the ischemia trial has not yet been fully published for us, and so we can't enter into the post-ischemia era until we've entered into the ischemia era by seeing the paper. How is the anticipated results of the ischemia trial going to be impacted by our physiologic testing?
Yeah, well, I think that, yes, I agree. I mean, we cannot declare the post-ischemia era until we can see the data, until there is a scientific debate about what, the authors report on this very important trial. But I think that from what we already know, because the message of ischemia was already there, it's coming a long way from courage through many other pieces of evidence. I think that we will agree completely in that what we have to avoid are unneeded interventions. Yeah. This is something that is extremely important. So in that regard, I think that the investigators of the ischemia trial and the interventionists who are using physiology-based revascularization will completely agree. Do not perform interventions that, are, unless you have a clear evidence that there is ischemia-generating stenosis.
Okay. So this has been very brief, but very intense. I enjoyed speaking with you. I hope our audience did too. I'm going to say thank you very much and join us again.